These are my disclosures. The idea behind today's topic is to basically demonstrate and report on the mid and long-term results of the Nautilus embolization for wide neck aneurysms, and also to highlight the results of the tornado study that was conducted in our distant department. So last year, thanks to the committee and of course Paul, I was invited here to report the very first clinical experience with the Nautilus embolizational device. So I'm not planning to annoy you with the anatomy of this wonderful beast. However, I would like to play this animational video. Can we play it on the screen? Thank you. And I'll do my best to narrate it. It's an intravascular system that is dedicated to facilitate coil embolization of wide neck anatomy. It's compatible with the modern 0.017 catheter technology, meaning when you're satisfied with your catheterization inside the aneurysm, you basically start to insert the device inside the sac. It's made of nitinol, and when inserted into the human body temperature, it starts to form that predetermined discus shape. When it's fully deployed, you can manually retract it at the level of the neck aneurysm interface and increase its compliance and provide enough reconstruction of the wide neck. Then, of course, you proceed with navigating of the second microcatheter inside the central pole of the device, and you can start adding your coils. When you're satisfied with the degree of the embolization, you can basically manually detach the device and separate the whole system and go home. There are no intraluminal components inside the parent artery vessel, meaning there is no need for DAPT therapy. This is the system in action on the fluoroscopy when we try to utilize it for the reconstruction of this relatively large and ruptured MCA aneurysm. Both of the MCA branches were actually incorporated inside the neck, so we thought it's a good idea to insert the device and try it out. We navigated the Nautilus, deployed it across the aneurysm neck, and then we proceeded with the navigation of the second microcatheter inside the aneurysm. We obtained successful navigation through the central pole of the Nautilus, and then we proceeded with the coiling. What we believe is the key benefit of this technique is the increased metal coverage. We all are familiar with the difficulties that the wide neck morphology pose. Flow diverters are even more often used for wide neck morphology, but they provide up to 42% of metal coverage across the aneurysm neck. Almost similar neck coverage is obtained with intrasaccular flow disruptors like the Webb device, but according to the manufacturer, the nitinol morphology and the nitinol nature of the Nautilus and the funny discus-like shape actually provide up to 90% of metal coverage across the aneurysm neck. This, of course, promotes progressive biological remodeling, and these images are taken from the animal study that the company produced with the Nautilus. There are zones with scattered endothelialization and biological remodeling across the struts of the nitinol implant. Similar observations we came across, a ruptured ACOM aneurysm where we actually embolized with some sort of a residual aneurysm still feeling. On the first control, 6 months later, the aneurysm was fully occluded with complete remodeling of the parent vessel artery and the neck. Same can be said for this ruptured ACOM aneurysm. There was still contrast feeling inside the sac at the bottom, at the final angiography over here. But on the first control, 6 months later, the aneurysm was completely gone. That's a beautiful case of the biological remodeling across the parent vessel interface. A ruptured MCA aneurysm where we placed the device. We inserted a few coils, but still there was some residual at the end of the procedure. 3 months later, there was ongoing process of new endothelialization, as you can see those defects over here. And then on the first year control, complete remodeling of the MCA bifurcation and absence of the aneurysm. Now, When it comes to sizes, the Nautilus implant and the whole system is available in 4 distinct sizes, ranging from 4 to 7 millimeters in diameter, meaning that majority of the aneurysms we face daily in our daily practice are suitable for this approach. However, we advocate in oversizing the implant with 0.5 millimeters over the diameter of the neck, meaning aneurysms with like 8 point something millimeters in diameter would somehow pose limitations to this approach. We were fortunate enough to be included at the very last moment into the post-market study called Tornado, but fortunately we managed to render 28 out of the 30 patients included in this study. As you can tell, majority of the aneurysms were located at the levels of arterial bifurcations, and the minimal neck diameter suggested that they had wide neck morphology. We felt confident to render some rupture cases. That's why this is because we believe that the Nautilus does not have any intraluminal implants, meaning that no DAPT therapy needed. So what were the results? We had the chance to be evaluated by third-party core web. The obtained results were kind of impressive, not gonna lie. 81% of immediate occlusion after insertion of the coils in the Nautilus, and up to 93% on the first radiological follow-up. So the technique was actually carried out successfully in all of the patients, and there were no retreatments in this group. Speaking about safety, no device-related SAEs, no procedure-related SAEs. 3 patients unfortunately died due to secondary natural cause of the SAH. There were no mortality, no morbidity related to the procedure at the first clinical follow-up. In context of embolizational rates, of course, we obtained quite significant results that are more or less comparable with the WEBIT in the SEROS study. Of course, we advocate not to directly compare our results to the WEBIT because of our study protocol only included 30 patients and the cohort is still small. So I'm gonna show you briefly a few cases that we managed to obtain longer follow-up. This is a ruptured PCOM where we actually embolized and utilized the Nautilus to reconstruct the wide neck morphology of the aneurysm. You can see there was still some contrast entering at the level of the neck on the final angiography with the complete remodeling 6 months later, and the 1-year follow-up confirmed the complete obliteration of the aneurysm with no signs of recanalization. Similar can be said for this giant ICE aneurysm that we actually planned for coiling post-flow diverter. However, on the final angiography, there was still contrast coming inside the sac, but with the further follow-ups, the aneurysm actually obliterated itself. This is the final MRI. The patient actually demonstrated quite a lot of volume reduction of the said aneurysm. As you can see, the aneurysm basically reduced with 1/3 of its size. The aforementioned case of the ruptured MCA, where we approached the Nautilus, there was some residual filling at the final angiography, seen over here at the bottom of the aneurysm. Similar findings on the first 3 to 6 control, and then 1 year later, complete remodeling of the MCA bifurcation. Another case, another recent case, a ruptured basilar aneurysm that we managed to coil with the Nautilus. These are the images right before the insertion of the final coil, and these are the final results on the 3 months control. Another relatively large neck ACOM aneurysm with both A2s adjacent to the neck interface. What we did over here, we used 4 millimeter Nautilus to reconstruct the neck, then we coiled the aneurysm, as you can tell on the final angiography here. Of course, we got comfortable with using the device, and we felt confident to utilize this technique in non-saccular morphology. This is a patient with giant partially thrombosed serpentine aneurysm, and we plan to occlude the aneurysm and the parent vessel with coils and Nautilus. Of course, we did balloon test occlusion to confirm the prominent supply from the MCA. However, what we did was we inserted a 4 mm Nautilus and then coiled proximally the aneurysm, and this was the final result at the angio. One of the recent cases that demonstrates the progressive occlusion, this was a ruptured ICA aneurysm with very tortuous anatomy. We couldn't complete the coiling, as you can tell over here, due to the curved ICA and the tortuous anatomy. We left some residuals, and we actually scheduled the patient for flow diverter next month. When the patient came, this was the final result, and there was no flow diverter needed. So in conclusion, we believe this is a nice addition to the current technology. It provides a lot of neck coverage and good support to facilitate the coiling. The wall profile of the system is actually a key benefit. The obtained results, they suggest a good occlusion profile and good safety profile, and the absence of the APT actually allows for you to go for ruptured cases. Thank you very much.